One. We are live now.
Okay, so good morning, everyone. And today we have Journal Club. It has been a long time. We have not reviewed recent papers. Dr. Goda and me had digged out 10 interesting papers from 2022 and 23. And we chose 4 papers which needs a lot of discussion, and although it claims that it would change our practice, but we have to do proper dissection of those papers and see are those really practice changing papers. And we have my dear friend Dr. Sandip Vaidya from Mumbai to moderate this session. And frankly speaking, I could not go through all the papers in detail, so I'm quite interested. And Sandip, you have to dig through these papers, okay? So yes, Meet and Goda, please start the session.
Yes, sir. So today, so for our journal club today, we have Dr. Sandip Vaidya, sir. Sir has done fellowships in multiple national and international fellowships, and sir is currently working as a consultant pediatric orthopedic surgeon in Mumbai. So we welcome you, sir, and thank you for taking time out for us fellows for this journal club session today.
One more thing which I would like to add is Sandip and Mandar, they have written a nice book on pediatric trauma. And that trauma book is more focused on international as well as Indian scenarios. So all the fellows, I would recommend to go through that book. It's a good investment and to keep in your library. It is involving a lot of good techniques, and I'm sure it will be of great help to all of you. Yeah.
So, thanks, Maulin, for the invite. I think we can start with the session now.
Yes. So the first paper that we'll have will be by Dr. Chinmay, sir. So, sir, if you would like to share your screen.
Chinmay, can you?
Yes. So my screen is visible now?
Yes.
So good morning, everyone. So in today's fellow meet, we are discussing about the recently published paper in JPO. So myself, Dr. Chinmay Sangole, I'm a pediatric orthopedic surgeon currently working in Amravati. I'm reading a paper which was published in JPO March 2023, which was study was conducted in Boston Children's Hospital, and the authors are Peter Waters and Donald Bay. The topic of the paper was corrective osteotomy of symptomatic radial head and neck malunion in skeletally immature patients. So this is a therapeutic level 4 study. The aim of the study was to analyze the result of corrective osteotomy for symptomatic radial head or neck malunion in skeletally immature patients. In materials and methods, so they defined that the radial head or a neck malunion within the 16 days of initial injury. If there is a persistent radial head malunion at 60 days, they opted for the corrective osteotomy. The indications for the corrective osteotomies were pain, functionally limiting loss of motion, and radiocapitellar incongruity. For the radiocapitellar incongruity, they mostly go for the advanced imaging in the form of CT scan or MRIs. So there were total 13 patients, 4 were males and 9 were females. So out of 13, the initial treatment which was done in an acute setting was splinting without reduction in 6 patients, close reduction in 4 patients, close reduction with pinning in 1 patient, and open reduction in 2 patients. Interestingly, in 8 patients, they accepted the usual universal criteria, that is less than 30 degree and less than 30 millimeter translations. So they accepted it in 8 patients, and in 11 patients, 1 X-ray had a joint congruency. But on a subsequent follow-up for the next 4 to 5 months, they found that these patients have a joint pain, elbow stiffness, or elbow FFD. So they were opted for the corrective osteotomy of these patients. In a demographic and injury characteristics, we can see that age at injury, they are pretty much of towards the adolescent age group, that is 11.7 with a standard deviation of 2.2. Age at osteotomy is approximately 6 to 7 months after the initial treatment. It is around 12.3 standard deviation 2.3. Injury. This is the interesting part where the injury which was associated with the radial head, neck, and fractures. So they divided into 3 parts. Isolated radial head and neck injury is in 5, and associated injury, that is other injury with intact ulna is 5, and isolated Monteggia fracture is 3. But they again didn't subdivided this part. I mean the other injury with intact ulna like elbow dislocation association with joint stiffness, or a isolated Monteggia fracture associated with joint stiffness or elbow FFT. They club it into one group only. In a results, for a corrective osteotomy, they took the standard Kocher's approach, and they do a closing wedge osteotomy for the radial neck malunion, and for the radial head malunion, they do a headless screw fixation and post-op immobilization for 3 weeks, which was followed by the elbow range of motion exercises. In the results, the clinical and radiological outcome after osteotomy, if you see the closely, the pre-osteotomy angle degree was 23 degree. Whatever traditional thought we are thinking about, that less than 30 degree of angulation and less than 3 millimeter of translation are remodeled according to ages. But here they operated at minimum 23 degree pre-osteotomy, and after post-osteotomy it is 8 degree. The displacement is 27% and post-osteotomy is 3. Elbow terminal flexion was 112 in pre-osteotomy and 128 in post-osteotomy. Elbow FFD is 18 degree. Pronation supination didn't change as much, and they specifically mentioned in the paper that realistic approach to the parent should be given, that elbow flexion is improved, but change in a pronation supination will be not that good. But the specific reason for that they didn't mention in it. So in a discussion, they suggest that in an acute setting, it is difficult to assess the radial neck angulation and translation. So radiographic assessment with additional oblique views are required to see for the any congruency. They specifically mention all the discussion part about the radiocapital congruency. They mention about the if there is a radiocapital incongruency with additional imaging if available, we should go for the fixation of this fracture irrespective of the degree under translation bit, because it eventually leads for the stiffness, instability, and ultimately joint arthrosis. Remodeling potential is low and cannot be relied upon the correct established bony deformity, which was recently published in 2022. They mentioned, and they specifically cited this paper why they operated this child on 23 degree also. Joint congruity are prioritized over the facial preservation. They compare the radial neck fractures to the femur neck fractures, that when we have a radial neck femur neck fractures, we go for the anatomical congruency, anatomical reduction. So similarly, we have to think about the radial neck fractures also. The limitations of the study, apart from the retrospective study, no comparative, no long-term follow-up, I think these are the another limitations of the study which I thought, that is the consideration of associated injury around the joint line, that is the elbow dislocation, ligamentous injury, or any other factors around the elbow, which will also cause for the joint stiffness or elbow FFD. They didn't specifically categorize that part. Pre-osteotomy angulation range, which is little bit controversial for everyone, because below 30 we anyways left it out. I think age less than 10 and more than 10, but I mean the pre-adolescent and adolescent age group angulation range should be defined correctly, so we can get long-term follow-up of these studies. Are we considering the reconsidering the acceptable limits for the fractures through these papers? These questions repeatedly came into my mind whenever I read this paper. And a late presenting fractures. When we have a late presenting fractures, we try to leave it, but looking at this paper, the importance of radiocapital congruency, I think this should be there should be a chance to correct this deformity. And our Orthokids technique has always rely on the anatomical reductions. So we can add this. So we can think about the anatomical reduction with Orthokids techniques. In the implication in practice, I think operating the child on 23 degree or elbow FFD of 18 degree, if we follow this child for more period, like 1 year, up to the 1 year, because they operated at the month of 7, other modalities like some soft tissue, some casting and elbow extensive physiotherapy will help, or the long-term follow-up we should consider. And the importance of radiocapital congruency is an important part which I came to know from this paper, that radiocapital congruency in a lateral view in X-ray, or if provided additional images, is important, because this will ultimately lead for the joint arthritis, elbow stiffness. So whenever go for the radial neck fractures in an acute setting or in a late presenting, always look for the radiocapital congruency in lateral view. I think this is the most important part I get from this paper, apart from the osteotomy. I'm a little bit skeptical about doing the osteotomy at 23° or in that range of. Thank you.
So that is nicely read paper. Now, one thing we must understand is there is incongruency can happen at radiocapitellar joint, and the radiocapitellar joint is well aligned and neck is angulated, meaning that the shaft has moved in a certain direction so that it is making an angle. So the earlier recommendation of 30 degrees is actually based on the angulation of neck, provided the radiocapitellar alignment is there, So that we have to see, because this incongruency would happen or persist in patients who have associated ligamentous injury or a dislocation, and then it will not remain congruent, and then can give rise to arthritic changes. So that we have to make sure, even after we reduce the neck fracture, which is completely toppled off, that should align after a close reduction technique. If you find the shaft is shifted, shaft is angulating, but the radiocapitellar alignment is good, then we can accept certain degrees of angulation less than 30 degrees. But if the radial head is tilted and the concavity is not matching that of the capitellum, then it needs good alignment, anatomic alignment. Yes, Sandip, what is your take on this paper?
I think it was a very good presentation. Few points. So mainly, regarding the indications of this surgery, whether it is, in what cases is it needed? So I think, what the authors should have done is they should have included only the isolated, radial neck fractures. Because when the fracture is associated with other injuries, like say an ulna or olecranon fracture or an elbow dislocation, obviously the stiffness is going to be much more in those cases. And whether the stiffness is just because of the radial neck angulation, or it is because of overall injury to the the capsule and the ligaments, it is difficult to differentiate between the two. So that is one point. Now here, as he mentioned, almost 8 out of 13 cases, they fitted the acceptability criteria. Okay, so the angulation was less than 30 and translation was less than 30%. So are the authors suggesting that we have to critically again re-evaluate our acceptability criteria and maybe become more stringent and aim to achieve a good anatomical reduction? Probably with your method of close reduction, that is possible to do it easily. But what if you don't get it? Then what are you going to do? Are you proposing that we go ahead and do a say mini open or something, or do more aggressive techniques to reduce that? That's a question which is a bit unanswered. Also, another thing regarding this radial neck angulation, what has not been really studied is, does the direction of the angulation make the difference in terms of the limitation of range of pronosupination? I have a feeling that, if the angulation is purely in the coronal plane, that is, the radial head is displaced laterally or angulated laterally, the restriction of pronosupination and flexion extension would probably be lesser than if the angulation is in the sagittal plane, that is anterior posterior, because that would lead, number one, if it is anteriorly angulated, it would lead in a flexion block, And also the congruity, the radial head, it fits into a notch in the ulna. So that would be lost, that the congruency of that joint would also be lost. We are talking about the radiocapitular congruity, but what about, the radial head has to rotate within the sigmoid notch of the ulna. So that is another, thing which needs to be studied. But overall, I feel, that radial neck fractures firstly are, rare injuries in children. Seeing, such malunited radial neck fractures is even more rarer. But suppose we come across this situation, I think this is a valuable technique, this is a valuable reference, which we can refer to and offer the children, evidence-based treatment based on that. Regarding the technique, how have they fixed each of these, osteotomies?
Yes, sir. For the radial neck fracture, they do roughly a close wedging osteotomy and fix with that T plate, sir. That radial.
T-plate.
Yeah. And for the radial head, they use a headless screw, sir.
Yeah. But you have to be extremely careful to preserve some soft tissue and periosteal attachment of the radial neck. So it will have to be a very, the osteotomy, it will more like what you call a corticotomy while doing a lengthening or something like that. You can't do a circumferential, allow the periosteum to be damaged circumferential.
Sir, are we then considering that less than 10 years will be good for 30-degree and more, and going towards the adolescent, we go for the anatomical?
The Chinmay, I mean, I again would like to bring your attention. See, let's assume we are talking about hip. So a subluxated hip is prone for arthritic changes that we all know if we don't put it back. But if there is hip is located, but there is coxa vara, okay, that is a different thing than subluxation. Same way, a radiocapitellar incongruency means there is subluxation of radiocapitellar joint that is different than an well-located radiocapitellar joint with angular deformity. So, in an isolated radial neck fracture, where there is no ligamentous injury, there we can reduce, and there after reduction we have to check this radiocapitellar joint is congruent both in AP and lateral view. To me, it looks like, although they have mentioned that isolated neck fractures and isolated radial, so there would be residual translation or residual subluxation of radiocapitellar joint. So that we have to make sure that it is well aligned. So these two things are different.
Okay, sir.
Probably that 30-degree thing still lasts. Again, if you see why they have intervened early, they have intervened at 60 days. That means only 2 months after index injury. So they have not waited for remodeling to happen. Now we know that proximal radius grow at very slow pace compared to distal radius. So to expect a neck angulation, we have to wait for at least a year, while they have intervened at 60 days, meaning that they were worried about the non-congruency of glenohumeral, I mean the radiocapitellar joint. And that is what, I mean, I think we have to reassess the what they are exactly talking. So they are talking about non-congruent radiocapitellar joint more than the neck angulation.
I think so.
But we can write to them that what are your specific, if a radiocapitellar joint is congruent and the neck angulation is 25 degrees, would you do this osteotomy or you would wait? You know, that's what I mean to say.
Yes, sir, I got it.
And so that is that's the reason why they have not waited and they have intervened early. Rest of the thing Sandip has mentioned, and I agree with him. We can inquire, because this needs to be understood very clearly. You know, otherwise some primary will see that why we are accepting 30 degrees here, angulation is less 23. Why they are operating? You know, that would be the question. But these angulations are associated with non-congruous radiocapitellar. Yeah, Gaurav?
Yes, sir. I also agree with this point that these two are different things: radiocapitellar congruency and malunion at the radial. Because in their range, they have mentioned that for 5 degrees minimum range of angulation they have operated. For 5 degrees, I don't understand how you can make it congruent by correcting 5 degrees. So I think the title is a little, I'm not agreeing with the title that to correct the congruency, you have to do the radial neck osteotomy. So these two things are not, I mean, I'm not able to understand this.
The second thing is, you see this, any operative procedure, like Sandip would also agree, open operations, it invites stiffness. And you see, the rotations has not changed much after surgery, you know, only flexion has. So there was lack of 40 degree of rotation in each plane and pronation and this. So this is more of a lateral view issue where they have reduced the radial head back into this, and the flexion has improved, but rotation has not. So this is probably because when we operate anatomically, there is some callus formation and it obliterates the radioulnar joint also, and that leads to limited rotations. So that is very important point that we have to tell family that this child would have limited rotation. But the key thing is, this is although it is rare, it is a very important injury. When rotation becomes restricted, it's a very difficult problem to deal with. Let's move on to the second paper. This one, thank you, Chinmay. Nice reading and nice dissection of the paper.
Thank you so much.
And you can draft a email to Dr. Waters, and I will send to him, to Don Bay, and then we'll CC to all of you. Let's you and Gaurav can draft an email and send to me, and we'll send it to Dr. Waters.
Hi, good morning, everyone. So today's second paper is about relapsed congenital vertical talus deformity and outcomes of a modified minimally invasive method. This paper was written by Dr. Pooya Hosindia and Jason Cummings, and it's from Washington University, published in JPO in March 23. So in the background of this paper, it's a level 3 study, and they discussed that traditionally CVTs were managed with open and dorsolateral releases. However, the complications were realized in 80s and 90s, where osteonecrosis of the talus, hindfoot valgus recurrence, and wound issues were quite well established. And after Dobbs' introduction of minimally invasive technique, they found that no osteonecrosis were found, and however, some degrees of relapses do occur, and as high as 40% of relapses have been mentioned in studies. However, no study has specifically tried to study the outcome of minimally invasive technique as a method for management of recurrence of CVT. So they started with this hypothesis where modified Dobbs is an effective treatment for management of both cohorts. However, they hypothesized that non-isolated CVT would be more likely to experience further recurrence or would be recalcitrant to treatment.
What do you mean by both cohorts?
So they tried to study
the primary and recurrence?
idiopathic and non-idiopathic CVTs under this. So all of these are recurrences, but recurrences with underlying etiology of idiopathic and non-idiopathic. So this is a study.
I'm sorry, Shalin. So Dobbs method means they have done mini open reduction of talonavicular joint and placed a wire, right?
And pinning, yes, sir. And T8 anatomy.
Primarily,
Yes, sir. So it's a single pediatric center study over retrospective study over 15 years from 2006 to 21. They defined recurrence as all cases who had a prior surgery. Any surgery was included, and they included all cases where pre-op and post-op radiographs were available, so they could study the outcome, and all cases with at least 12 months of follow-up after the revision surgery were included. They defined recurrence as lateral tamba measuring more than 30 as described by Dr. Hamanishi, and the final outcome was measured by AP and lateral talocalcaneal and tamba angles, and all of these were measured by a single author at 4-week difference for all the X-rays, so as to take out the intraobserver reliability.
Can you de-abbreviated tamba, because there are a lot of other fellows who might not.
Talar metatarsal base axis. So this angle should be less than 30 degrees in normal, and in a forced plantar flexion view, if it remains persistently more than 30 degree, it defines congenital vertical talus. So either a fixed dorsal dislocation of the navicular or a tamba more than 30 degree, both are defined as congenital vertical talus. So this is the technique that they use. So they did quote the modified Dobbs technique, and they used weakly reverse Ponseti casts, followed by a minimally invasive reduction of the talonavicular joint fixation with K-wire, followed by a percutaneous stenotomy. They did extensor or tibialis anterior transfer, or a extensor or a tendo or a tibialis anterior tenotomy as and when required. And the bracing protocol was as mentioned, and children after walking age were braced for 1 year, and before walking age were braced for 2 years, and all were regularly monitored for relapses. And
Shalin, any
results,
mention of the endpoint of casting? I mean, how did they decide that now casting is enough? Now we go ahead.
they have not specifically mentioned, but they quoted the Dobbs paper where they could find a reduction in the plantar flexion view of the talonavicular joint, after which they went on to minimally invasive method. But because they have used open, they have taken the liberty that when it did not reduce, they used minimally open in all of the cases. So they have not specifically mentioned it. Because it's a retrospective study of 15 years, they are mentioning the limitation that all of the data was not available for them to study.
Sandip, what do? You take X-ray to confirm that the talus and metatarsal are aligned, and so I can, or judge clinically.
I take X-ray, but to be frank, I've almost never, in a true CVT, I have never almost achieved a talonavicular reduction with just casting. It is
So
always at in a true CVT.
Yeah. So in true CVT, idiopathic one, non-syndromic, my practice has been clinically when I feel that I can feel the navicular and talar in one axis on the pulp of my thumb, then I get an X-ray, and we see whether this talar axis is matching the metatarsal, first metatarsal axis. And when we open, it need not to be 100% reducible. Then you have to lift the talar head and put a retrograde wire. So there is sometimes a bit of pressure, but that first you judge clinically and then get an X-ray and then take decision to take the child in.
Absolutely.
It's not easy. It's not that easy. I agree with you. Yes, Shalin, please go on.
So in results, they had 17 patients and 24 feet. The 17 patients, 9 had neurological etiology and 8 were idiopathic. And from the 17 patients, 7 required open surgery, and 10 had a minimally invasive surgery pre-operatively. So they had open surgeries pre-operatively as well. And average age of the child was 26 months, with the range from 7 months to as high as 5 years. Total 14 children required revision surgery after walking age, which is a majority of the children with 82%, and 18 did not require any other soft tissue releases, just standard modified Dobbs with no other tenotomies or tendon lengthenings required. Pre-operatively, average casts were 4 casts, and average follow-up was of 4 years, which is a large follow-up for this cohort. So in results, they studied the AP and lateral, talocalcaneal, and the talametatarsal base angle. Pre-operatively, all of these were abnormal, and at the final follow-up, all of these turned to normal except the AP talametatarsal base angle, which suggests slight plano-valgoid feet. But the only significant change they could find was in the lateral tamba angle, which improved from a pre-operative average of 70.2 to a post-operative follow-up of 24.9, which was significantly improved. The rest of them did improve, but the improvement was not significant. They also found that when they compared the outcome of idiopathic and syndromic feet, they found that the significant difference was only in the AP talocalcaneal and the AP tamba angle. And this was significantly different at 1 year post-operatively. The rest of them, there was no significant difference between these two subgroups when this technique was applied in recurrence cases. And when they tried to study recurrence after this revision surgery, they found that radiographic recurrence was seen in 12 feet, which is 50% of the cases. And this radiographic recurrence was AP as well as lateral views. So a planovalgoid feet or a increased in Tamba, both were considered as recurrence. Patients with recurrence had greater preoperative lateral Tamba, which was significantly different from the children who did not have recurrence. Recurrence in syndromic patients was double the rate of those in non-syndromic. So 64% compared to 30% in non-syndromic. However, this difference was not statistically significant. And 6 feet out of 24. So 6 feet in 4 patients, so 25% of feet ultimately required a revision surgery. And all of these were syndromic. Hindfoot valgus was seen in 5 patients, which is 21% of this subset at the latest follow-up. And one thing they found was that males have a significantly higher rate of recurrence compared to the females, which is 75% compared to 25%. And they also tried to apply PROMIS score, which is patient-reported outcome. They could apply this only in 9 patients out of the initial 14, and 8 years. The average age of the child was 8 years and average 5 years post-surgery. And they compared this to standard, and there was no significant difference in the pain interference, no significant difference in mobility or peer relation domains of the average score. The only significant difference they found was when they compared the 2 subgroups, which is syndromic and idiopathic, and the underlying syndromes had reported higher pain interference score compared with idiopathic CVTs. And they tried to compare the results with previously published studies where they had mentioned recurrence. And they did find that Dobbs himself had 6 feet recurrence in idiopathic cases where they managed with cast and pinning, which is the same similar technique, but without open reduction. And in non-idiopathic cases, in 2012, Dobbs mentioned 5 feet with recurrence, and all of these were managed with open reduction and pinning. The Hafiz study had 5 feet of recurrence, who all of them were managed with surgically, 3 with modified Dobbs and 2 with an open surgery. However, the Hafiz study mentioned that all of these still recurred after the repeat surgery. So ultimately, they conclude that syndromic are significantly more recalcitrant to treatment. Supplementing additional soft tissue surgery should be considered in syndromic patient because of their chances of recurrence. And they conclude that this technique can be used for recurrence even in even in patients who have been managed with open releases priorly, because out of 4 cases were successfully treated with this technique even after an prior open release. And they conclude that this can be successfully used in idiopathic cases with recurrence because none of them required an additional surgery. So when we review this, still a lot of questions remain. So there were 50% radiological recurrence, but only 25% of them requiring a revision surgery. So this discrepancy is not explained. So 30% of recurrence, radiological recurrence is seen in idiopathic cases, which is quite a high number of cases. They have not included the calcaneocuboid joint open reduction in recurrent cases, which is already known to be one of the very important factor for, which has been mentioned by Dobbs to be one of the important cause of recurrence. And they have mentioned in the discussion that they have used this a la carte algorithm, but they have not mentioned what a la carte algorithm. So, which is quite well mentioned in one of the Dobbs paper where to do the tibialis and T anatomy, where to address the peroneus longus or brevis. And they might have, this paper might have given us more details if they had tried to study the reason for recurrence. So the primary surgery, whether they included calcaneocuboid releases, whether the primary surgery included any other tendon releases. And the PROMIS score is not much of significance because only 9 cases were studied, and with just 3 idiopathic cases, the difference between these two might not be quite relevant right now. One of the error in this paper I found was that they quoted the Dobbs study from 2006 And they said in this paper, they have mentioned that 4 cases of recurrence. However, the Dobbs original paper, there were 3 patients and 6 feet which had recurrence. So I think this is one of the error which has been missed by the authors as well as the reviewers. And one another issue is that they have not tried to study the cause of recurrence, which has been studied in all the other papers. So Dobbs mentioned that not pinning was the cause of recurrence in idiopathic cases. In the second Dobbs study, he mentioned Coleman type 2, the calcaneocuboid joint as the reason. In the Heffes and Davis study, all the cases with recurrence were syndromic. However, this study does not, even though it is trying to study recurrence, it is not it does not try to understand the cause for these recurrences. And one of the other small issue I found was that they have divided open and minimally invasive surgery difference in 17 patients. However, these should have been divided based on the number of feet which were operated. So it may not be necessary that all patients with bilateral feet were managed bilaterally with open. So if they used the 24 feet as the base, and the number of feet requiring open surgery and minimally invasive surgery might have given us a better idea. And also the total number of CVT cases which were managed over this 15 years, and the number of the subset of these requiring actual recurrent revision surgery would also give us more idea about the baseline data. And one other small finding is that they considered p-value as less than 0.05, but not only first year post-operative, at the final follow-up also, the p-value for comparison of AP TAMBA between syndromic and non-idiopathic is almost 0.05, which is almost significantly different. So this, at 1 year, this is significantly different, and the recent follow-up, it is not different, does not hold water. So I think based on this, we cannot just change our practice and use this technique for all our recurrent cases, and more data and more analysis is required before we use this paper in our practice. Thank you.
That's right. So Shalin very nicely reviewed paper, and I mean, there is a zeal of publishing paper, you know, and you see there are 24 feet over 15 years. So there are 17 patients over 15 years. So 1 patient a year, and so many authors. Let me tell you the Dobbs papers history. You know, when I was at CORR at that time, 2008, his earlier publication or study was a reverse Ponseti technique for CVT. And that time he, early on, he just used to do reverse Ponseti and clinically judging with some x-rays, and then he would do tenotomy. And then he found that, oh, this is coming back. So then he started putting a wire across without opening. And that a 1 year follow-up, they are also getting recurrent. They are coming back. And so then he started doing mini open thing. So at that time, we started following at CORR. Dr. Jim Wright was the in charge of this foot department. And then we also had the same, like if you just put wires with close reduction, you will we'll see a lot of relapses. So he suggested, why not to do the mini open? And then this thing came. So if this paper is spanned over 2006 to 2015, that means these earlier cases were done by just trying to replicate what Dobbs suggested, but Dobbs himself had changed his practice. So 2006 to 2015, a different set of authors are treating patients, and now in 2023, different set of authors are reviewing the results based on the cases. So there are a lot of fallacies, you know. And if I have done an open reduction, a mini open reduction, and the deformity has recurred, I have to be very sure that now at this time, this intervention should be the last intervention. And we just cannot keep on doing casting under anesthesia. We want to make it 100%. What if you do 3 casting and if now it is not bursing? So now let us do an open surgery. No, the parents want a clear answer that you do 1 intervention and make it sure. This is, I'm talking about our perspective. So this is the power of study is also very less. A lot of variables, number of patients are less. One more thing, Dr. Vince Mosca said that Tamba is also not very reliable marker. We know that Dr. Ponseti himself said that there might be some spurious correction. So there might be radiologically undercorrected clubfoot, but clinically it is corrected. Because these ossification centers are not centers, So the Patellar ossification center does not give you the true axis of talus. And that is the reason why radiologic recurrence is not actually the true recurrence. You still have to see clinically how the foot looks. And if you see that 30% patients, when you have done mini open reduction as a primary treatment in idiopathic CVT, 30 to 35. So every 1 child over in 3 is getting recurrence. So that might be happening because a surgeon who is operating in year 23 and now the second case he will do in 2026. So there's a lot of fallacy of this paper, and I would not change my practice that an idiopathic CVT would come back to me. I would go for the conventional open procedure where I would do lateral release. I would do medial alignment, plication of tip post, undervision reduction, and TA tenotomy, or if required, posterior capsular release. So I would not follow this paper. That is my take on this. Sandip, what do you think?
The neonate that comes to me with the CVT, I always start off with casting because it will not correct the deformity, but I believe that it will decrease the extent of the surgical release that will be needed in the later day. So I always tell them that the casting is just to stretch out the soft tissues, but he's going to need an open surgery at a later date. Previously, my primary surgery in CVT, I used to do by a Cincinnati incision. So a circumferential, subtalar release and realignment of the talonavicular joint followed by pinning. However, what I have observed is that this approach didn't tackle the tightness of the dorsolateral soft tissues. The peroneus tertius, extensor digitorum longus, peroneus longus brevis. Peroneus longus brevis, you can still do it through the Cincinnati, but the other. And that led to, a few of my patients, they came back with a recurrence after they started walking, where there was not a recurrence in terms of loss of, dislocation of the talonavicular joint, but the the subtalar joint went into eversion and external rotation. And that's why I feel that a dorsolateral release is an important component of the release. Now, coming to relapses, we have done seen a few where they have been operated previously elsewhere and come with a gross relapse at the age of 7 to 8 years. And in such cases, I feel along with the soft tissue release and realignment, you have to give consideration to a Grice-Green extraarticular arthrodesis in order to prevent recurrence. Because I agree that the subtalar joint is an important joint and you have to attempt to preserve mobility, but sometimes that is the only option that remains in very severe relapses if you want to prevent any further recurrences. So we have done Grice-Green in about 3 patients, and they are doing quite okay at medium-term follow. So that's a procedure which might be considered in severe relapses in very old children, maybe say 8 years, 10 years.
So if you any of you had attended this Palsy foot workshop, the Vince Mosca is quite aggressive. Any severe recurrence, they have done even up to naviculectomy.
Yes,
so they do talonavicular fusion, or in a very severe case, they would do the naviculectomy. But the question about this paper is, would you try a recasting in a relapsed CVT? The answer should be, because the number of patients is too low. And my suggestion or my experience, I would do a short shot. And so I learned this from Dr. Johari, that this 3 incision technique, Sandip. And that has been described by Carroll and all. So you do a lateral incision, posterior incision, and medial incision.
Separate.
That's one. The other way
So you
is
tackle everything.
Yeah, and or you just do one dorsal incision and do posterior tenotomy. So both are there, but I have been doing a 3 incision technique. One thing which like beyond this paper, what I found is when you do this idiopathic CVT and mini open reduction, you reduce the talonavicular joint. You have done PA tenotomy, everything is fine. Still the toes and forefoot is going into valgus. That shows that lateral structures are tight.
Yeah.
And at that time, one should not, probably at that time, we think that with casting, we will control this, we'll stretch this out. But at that time, these are the patients with idiopathic CVTs, which shows, although talonavicular joint is reduced, but foot is a bit everted, so lateral structures are tight. So in those cases, I also try to put a small lateral incision and release those tight lateral structures, even at the age 3-4 months. And we have to do one case next week. So there I'll be very skeptical. If not all lateral structures are released, I would put a small incision so that I'll explain to the family.
So just last week we did one case where on the lateral X-ray, the talonavicular joint looks perfectly aligned. However, when he's walking on the heel with the forefoot completely raised above the ground. That's because, the eversion and dorsiflexion is happening at the level of the subtalar joint, with the talonavicular joint still being, well reduced. So those are the cases where, you need to do a good, dorsolateral release. And Moshka has mentioned it in his textbook. He's given the technique, the surgical technique, how it is.
Fine. So Shalin, there's nicely reviewed paper. Now, Shalin is champion at statistics. So he could find out this small, and now you see this JPOA also. There's so many, the reviews are not very crystal, Yes, Gaurav, a comment?
Sir, I want to give my, opinion about it. In last 4 to 5 years, I have seen maybe 1 or 2 in a year, always syndromic. Most of the times I see severe planovalgoid feet, which are usually flexible flat feet, and they have been advised surgery, but they always improved without any intervention. Over a span of year, there are a few cases over advised surgery by people and they improved significantly. Those which I have seen is they have other issues as they are syndromic, so they get exhausted in 1 to 2 knee surgeries only. Like I do this hyperextension correction, and after that they either don't follow up or they don't want to get operated. And in one case, I casted a kid twice, and even he didn't follow it. So followed after that. Although clinically he improved, but then I don't know why he lost the follow-up. So for CVT, I have not even started my practice, so I don't know what to change.
No, it's like see arthrogrypotic children. Somehow, we see this in very, most of them are in very rural, urban or low profile Muslim families. It's seldom we seen very affording and, so for them undergoing multiple interventions, multiple time treatment without seeing outcome, so we have to be very realistic. If it's a syndromic vertical talus, we just, as Sandip mentioned, you do cast to stretch the soft tissue and to put to make the foot supple enough or straight enough to be placed in a thermoplastic splint. That should be our goal. for even CDK, many a time it doesn't give buzz, and you feel that even after doing percutaneous rectus release, it will not come. So then I just do a couple of casts and then fix them in a thermoplastic splint and come back at about 9 months to a year for surgery. I mean, there's for syndromic and arthrogrypotic myelomeningocele, they do not do well with this plaster treatment. So there you have to give minimum number of plaster, fix them in splint and bring them back for surgery. While idiopathic ones, which is quite uncommon, as I mentioned, I see one every few months, maybe 2 or 3 over a year. So that is not that common, see, and that you will see gradually as you build your practice. So in those cases, you will see, and even family would see an apparent correction after you start applying plaster, and then they will stick with you because they are also seeing improvement. For syndromic, just a couple of casts and then surgery, and then eventually now I say that this is not the last surgery, you will need multiple. So as we grow, we are more confident that patient is not going to run away from us, and then we give them very realistic. At younger age, when I used to describe this, patient would run away to Premal Bhai or Dhiren Bhai thinking that I'm a young surgeon. So पहले ये बोलते थे कि sir surgery आप करोगे, and now they are saying surgery आप ही करोगे ना sir. So that's the difference with your time. Yeah, let's move on to the next paper. So Shalin nicely read it, right?
Yes.
So I'll be discussing this paper, 4-in-1 Quadricepsplasty for habitual and fixed lateral patellar dislocations. The authors were Sheetal Parikh, Dr. Sheetal Parikh, Dr. Nicholas Loprieta, and Matthew Weirkamp. This was published in JPO 2023, and the investigation was performed at the Cincinnati Children's Hospital. So just to give a background, habitual dislocation of the patella is involuntary patellar dislocation and relocation with every cycle of knee flexion and extension, whereas a fixed dislocation is a permanently dislocated patella, which may or may not be reducible. So to have a look at the pathoanatomic features of habitual and fixed dislocation, the main pathology is a shortened, lateralized, and externally rotated quadriceps mechanism. There are soft tissue blocks like thickened IT band, tight lateral retinaculum, shortened vastus lataris tendon, tight biceps tendon, and lax medial structures. And there are structural abnormalities like trochlear dysplasia, patella alta, tibial tubercle lateralization, and patellar tilt. So the treatment options, there's no rule of conservative management, and the cornerstone of management is quadricepsplasty, which is done to reorient the extensor mechanism. The previous techniques that have been described, they have used wide lateral incisions to elevate the entire quadriceps and vastus lataris from the femur. The proposed technique by the authors was a 4-in-1 quadricepsplasty, which has been described before by the same author, Dr. Sheetal Parikh, and they have now reviewing the 2-year clinical follow-up of those patients. So 4-in-1 quadricepsplasty includes wide lateral release with retinacular lengthening, a Roux Goldberg patellar tendon hemitransfer, modified insult proximal tube realignment, and a sequential quadriceps lengthening. So just to have a view of what they do in the quadricepsplasty, in image A, there's a lateral retinaculum lengthening and a lateral and medial arthrotomy, which is done, and which is followed by transferring the medial retinaculum to the lateral side, and there's the patellar tendon is the lateral half of patellar tendon is shifted over to the medial side. This basically puts the patella and the quadriceps mechanism in a tube. So the aim of this study was to evaluate the anatomical risk factors in habitual and fixed patellar dislocations and a description of 2-year clinical outcomes of the 4-in-1 quadricepsplasty. So this was a retrospective study, and it was done in 12 patients with 17 knees with a mean age of 9 plus or minus 3.8 years. And the average age at onset of symptom was 5.5 years, and there was preoperative MRI which was retrospectively assessed, and this was done to assess 4 parameters: the trochlear dysplasia, patellar height, tibial tubercle lateralization, and the lateral patellar tilt. So for trochlear dysplasia, the trochlear depth of less than 3 mm was considered to be significant. A patellar height of a Caton-Duchamp's index of more than 1.2 was considered pathological. Tibial tubercle, the TTTG distance of more than 20 mm was considered pathological, and lateral patellar tilt of more than 20 degrees. Postoperatively, the MRIs were not available for all the patients, and they have, in a few patients, they have done postoperative radiographs to assess the patellar shape, position, and growth. So the outcome measures which were used by this study were the PEDI IKDC score, which ranges from 0 to 100, with 100 having a good activity. The HS PEDI FAB score, which ranges from 0 to 30, with 30 being most active. They used a BPII 2.0, which ranges from 0 to 100, with 100 indicating the maximum quality of life. Kujala score, where 100 would represent maximum function, and a knee injury and osteoarthritis outcome score, which ranges from 0 to 100, and 100 indicates that there are no limitations to activity. The authors have cited a previous paper where all these outcome measures have been validated in the pediatric and adolescent population. So moving on to the results, there are 17 knees. The habitual dislocation was present in 12 of them, and fixed dislocations in 5 patients. Habitual dislocations in extension were present in 9, and in flexion were present in 3. The syndromic association was found in 1/3 of the patients, that is 6 out of the 17 knees. Joubert syndrome was present in 2, Turner's syndrome is 1, Dijot syndrome in 1, and the nail patellar syndrome in 2. There were other associated features as well, but these were not studied in great details by the authors. So DDS was present in 2, CTV was present in 2, and fibular hemimelia was present in 1. The most common presenting symptom that the authors reported was repeated falls. So the results based on the MRI, trochlear dysplasia was the most common associated feature, which has also been previously described. And this was present in 88% of the patients, that is 15. Then patellar alta was the second most common was patellar tilt, which of more than 20 degrees, which was present in 12 out of the 17 patients. And a TTTG distance, a significant TTTG distance was present in 41.2%, and a patellar alta of significant value was they could not perform the patellar height measurement for patellar alta in fixed dislocations. So only the habitual dislocations were included in this, and 33% of them had significant patellar alta. There were no associated bone bruises, effusion, or osteochondral fractures. So the knee, clinical results, the knee extensor lag and flexion, they also have stated that it gradually improves in the first year, and 15 out of the 17 knees achieved full range of motion by the end of 1 year. The mean IKDC score was 88.1 with a standard deviation of 13.8. The HSS PEDIFAB score was 15.6. The average was with plus or minus 7.5. The BPII score was 78.2. A Kujala score of 90 and a KOOS score of 93.9 was reported by the authors. The authors reported complications there are 3 main complications that the authors faced. It was recurrent patellar instability, stiff knee stiffness, which required manipulation under GA, and a superficial wound infection. The author studied recurrent patellar instability in greater depth, and they found that all of these were habitual dislocations in extension. So they had to perform secondary surgery and perform an MPFL reconstruction with gracilis allograft. So moving on to discussion, the diagnosis was clinical and the confirmation was by radiology. USG or MRI was done. USG or MRI, the author stated that both of these are helpful to delineate the anatomical risk factors. 4-in-1 Quadricepsplasty involves approaching the patella from all sides. The authors have stated that a theoretical risk of AVN of the patella exists, but it was not seen in any of their patients. Previous studies have also required wide lateral releases and distal realignment procedures, and Z-lengthening of quadriceps were not required in any of the patients. The author has stated that when a post-operative, like an intraoperative knee flexion of 90 degrees was not achieved after reducing the patella in the trochlea, only then is Z-lengthening required, and in their series, none of the patients required it. So for future directions, all three recurrent dislocations which were seen were in extension, in habitual dislocation extension, and all of these had required MPFL or MPTL reconstruction, and this is further being studied in a different study. The limitations that I found was that this paper had a very small sample size of just 17 knees, and there was no quadriceps strength assessment to assess post-operative weakness, because the authors have stated that Z-lengthening of the quadriceps leads to a weakness. However, their patients, they have not assessed the post-operative weakness. Thank you.
So, Meet,
Yes, sir.
can you enumerate 4 steps of this reduction?
Yes, sir. So the authors, they first, what they do is they do a wide lateral release, and they do a medial and lateral arthrotomy. So then they do a coronal Z-lengthening of the lateral retinaculum in the coronal plane. So they say that the lateral retinaculum gets lengthened with that. Then they perform the Rue Gold with patellar tendon hemi-transfer, where they take the lateral part of the patellar tendon and transfer to the medial side. And then they when they have performed the medial arthrotomy, the medial part of the medial flap they use, they transfer it to the lateral pole of patella, and so they say that when the medial flap comes over to the lateral side, it forms a tube.
I know. So what are the 4 in 1 means? The lateral release.
Yes, sir. A wide lateral release.
Medial VMO release and advancement. Retinacular release, which already you need to do, and then hemi-patellar tendon shifting to the medial side, right? So these are the 4 steps, right?
Yeah, yes, sir.
So they are not doing semi-T tenodesis, which was a part of the initial original 4-in-1 description by Chu.
Yeah, yes, sir. They have not done semi-T tenodesis in any of these patients.
Okay, fine. And so this is a well described technique. I mean, way back in congenital patellar dislocation, and then now they are using it in habitual dislocations. And then if even after doing this, if you find like the one we did in Down syndrome, it was recently, that was very dysplastic trochlea, and even after doing Z-lengthening, it was very unstable. So what is important is to assess all these patients pre-operatively for their radiologic parameters, especially the trochlear groove, whether it is deep enough or not. Some of them are very dysplastic on the lateral side, and if whatever you do, it has still tendency of getting subluxation. Once we release the vastus lateralis and tensor fascia lata, and then we release the medial flap and align it. At that point, you check after taking a couple of sutures that whether you flex the knee and it gets out. So whether this quadricep is short or not, and then you do a Z-lengthening of the rectus. That's the thing. So I think this paper is good, this is what we have been practicing. We are not doing anything different, although we do sometimes this semi-T plication. So this paper would consolidate our practice rather than change our practice. Did you find any limitation, Sandip, in this paper?
No, I think the technique we have been doing since some time now. only what I wanted to ask you is how often you need to do that Z lengthening of the rectus, and does that result in an extensor lag or loss of extensor strength in the post-op period?
Yeah. So first of all, where we have seen it in syndromics and the ones which are old children and neglected dislocations. So like if a child comes at after 8 years, 9 years, so there, because of the long-standing dislocation, the quadriceps mechanism is shortened. There we required to do Z lengthening. And yes, they can develop weakness in quadriceps leg, but the priority is to put these patella back into its position, which is more important, because otherwise the natural history is they keep on having flexion deformities, and the quadriceps, they act as flexors. In very long-standing cases, it's very difficult to, some of those patients require femoral shortening, in order to bring the patella in position. So
Okay.
I would tell fellows that when you come across this patella dislocation, congenital ones, after 5 years, they are very challenging. For habitual and for traumatic, you can still go ahead with this, but assess their radiologically very well. And syndromics are more challenging. Yeah. So one message.
The one point that I should have mentioned, the authors mentioned that trochlear dysplasia, when they fixed it at the age of less than 11 years, they said that the trochlear remodeling could be expected. So they were in support of operating early on, but they have not performed a study regarding this. They have not studied post-operative trochlear dysplasia as well.
Right. So that was a good paper, and we are going doing the same practice. Yeah. Let's have go through the last paper quickly. Godha, can you share your screen?
Yes, sir. Is it visible, sir? So guided growth improves Coxa, Valga, and hip subluxation in children with cerebral palsy. So this study was done at National Taiwan University Hospital, Taiwan, and the chief surgeons were Quan Wen Wu and Tingming Wang. This was published in Clinical Orthopaedics and Related Research. So the aims of the study were: does guided growth with a transphysial screw prevent progressive coxa valga and lateral hip subluxation in patients with cerebral palsy? What are the factors influencing the success of this treatment? What are the complications? And is there a need for resurgery? Materials and methods. This study was a retrospective study which was conducted between 2012 to 2016. There were 25 children in which it was studied, and one was lost to follow-up because he did not have a minimum follow-up of 2 years, and it was not included in the study. So 48 hips were operated, 17 were boys and 7 were girls. The mean age at surgery was 8 years. And it ranged between 5 to 12. And adductor tenotomy, accompanied soft tissue management was done in 12 patients, that is 24 hips. So partially fully threaded screws and partially threaded screws both were used. So fully threaded were used in 20 hips and partially threaded in 28 hips. Out of these, 3 patients were GMFCS 1, 4 were 2, 7 patients were GMFCS 3, 7 were 4, and 3 patients were GMFCS 5. The indications of the surgery were, or the inclusion criteria was: migration percentage of the hip should be about 30 degrees, head shaft angle of greater than 155 degrees, and with at least 2 years of growth remaining. The study excluded patients who had the greater migration percentage, that is greater than 50%, and who were about 12 years of age. The technique that was used was they also did a simultaneous soft tissue surgery if required, like adductor tenotomy or hamstring release. So they placed the hip in internal rotation till they noticed a longest part of the femoral neck, And a guide wire was introduced aiming the medial 1/3 of epiphysis in coronal plane, centering over the femoral neck and lateral view. They have used a 6 mm or 7 mm CC screw based on the size, and all of the patients after surgery were allowed full weight bearing. The radiological outcomes that were measured were head shaft angle, Hilgenriner's epiphyseal angle, acetabular index, and Riemer's migration percentage. These were measured preoperatively and postoperatively and during follow-up. They also looked for signs of osteonecrosis, chondrolysis, screw back out, and the percentage and duration of screw back out in follow-up radiographs. The results of the study were there was an improvement in the head shaft angle by 13 degrees. The Hilgenriner epiphyseal angle improved to 15 degrees. Acetabular index decreased and it improved to 3 degrees of the previous value. And the migration percentage improved to 10%. So this was one case which they've shown. This was a 6-year-old child, and this was followed over a period of 4 years. And we can see the improvement in the migration percentage. The complications in these studies was out of the 48 hips, 21 hips, the proximal femoral physis grew off the screw. Hence, they had to replace the screw with a longer screw in 15 of the hips. And out of the 21 hips, 8 hips required a proximal femoral derotation osteotomy because the migration percentage did not improve. And discussion, this study authors compared their study with other studies, and they found that the mean decrease in head shaft angle was comparable to previous studies where it was 10%. Here it was like 13%. There was improvement in migration percentage with mean decrease of 10%. But they said that they required a longer follow-up and smaller preoperative migration percentage as it was associated with more improvement. They also discussed that replacing screws is necessary if their position in the physis is lost. And the previous studies showed that there was a correlation with age and degree of correction, but the authors have mentioned that there was no correlation with age and degree of correction, and guided growth can be done in all CP patients if they have a greater than 2 years of growth remaining. So, and there was also no difference between partially threaded and fully threaded screws used. And they also noticed that in spite of using a longer screw in resurgery, there were still improvements in the head shaft angle. They did not find any osteonecrosis or chondrolysis. And the 8 hips that required femoral osteotomy were GMFCS 5, and they had higher values, radiological parameters preoperatively. So this suggests that children with greater than 50% migration might not be good candidates for guided growth. The limitations of the study were it was a retrospective study, and there were no cohort groups. So patients who underwent only tenotomy were not included as cohort group to isolate the effect of guided growth surgery. And the limitation of studies without a cohort group are at risk of overestimating the apparent benefits of treatment. So how did they overcome these limitations, few of the limitations? So to minimize the selection bias, only the patients who met the surgical criteria were selected. Radiographic parameters were read by another author who was not involved in patient care. And head shaft angle was measured rather than neck shaft angle, which demonstrated less than 5% error for rotation up to 45 degrees. So in conclusion, we can say that guided growth with a transepiphyseal screw, it does not create a large degree of difference as with an osteotomy, but it can stabilize the hip in children with cerebral palsy with less than 50% migration. It is less invasive and hence a better choice in children who are too frail and have a lot of morbidity and difficult to anesthetize them for longer periods of time. So mostly useful for very frail patients. And guided growth also decreased the mean acetabular index by 3 degrees. So it proved that it could yield better acetabular development later on. But in patients with severe subluxation, where migration percentage is greater than 50%, a combined procedure is useful, a combined guided growth along with an acetabular procedure. Thank you.
So that was nicely read paper, Godha. Now the question is, why the hips look Coxa Valga, in cerebral palsy? Can you answer me that? Is it a true Coxa valga or it's an apparent Coxa valga?
Apparent Coxa valga also.
Yeah, because of what?
The adduction of the hips, which we see in patients.
No.
No, sir.
So anyone, why there is apparent Coxa valga in CP? Because of
Non-weight
because of, sorry?
non-weight bearings.
Yeah, but non-weight bearing leads to what? So, yeah, Shalin.
No.
Why in CP the hips look apparently valgus?
So the femoral anteversion does not change.
Exactly. So they have persistence of femoral anteversion, and that leads to apparent Coxa valga. So the X-rays which they have shown, they are in kind of external rotation because lesser trochanters were very prominent. So the first limitation I would say that they standardized these X-rays, in those who have attended this hip surveillance meeting, which was held in, and we have come up with a CP screening, hip screening X-ray. So how to take hip screening X-ray in cerebral palsy children? Who was there? Shalin, you were there?
Yes, sir.
Should we take X-ray in which position the child is lying, or there is a specific position where we should take?
No. So we should get the profile view. So the LT should not be visible, and we should correct for the flexion.
So we should take that in 15 degrees of internal rotation. Okay, to see the real migration. Because if you take X-ray in whatever position, neutral bit, external rotation, the femoral head will be in valgus and it would look laterally migrated. But if you turn the extremity with 10 to 15 degree internally with hips adducted, then you will see that is a true migration. So that is one. The reason of migration is the rotational deformity and not just the coronal deformity. And we are trying to correct a coronal phenomenon by putting in guided growth. So this is different than we see subcapital Coxa valga in DDH. There the lateral growth arrest happens and medial physis keeps on growing, and it leads to subcapital Coxa valga, where you can, Ian Terode and all, they describe this technique of medial growth modulation that works there, because that's a purely coronal deformity. So that is one thing. The second point is they have not have the controls. So what happens if we just do adductor tenotomy? The third thing is, what is the percentage of hip dislocation we see in GMFCS5, and what is the hip dislocation GMFCS1 or 2? So Chinmay, what is the rate of dislocation 5? How many hips would get dislocated in GMFCS5? What is the natural history?
So around 20,
anyone? Yeah.
Around 20 to 30% get start stabilization.
No. In GMFCS5?
As 80, I think 80, 90, I think.
90%. And about 60% in GMFCS4, while it is less than 10% in 1 and 2. So this outcome should be compared, they require revision surgeries in 5, which is very obvious. We need to see how many of GMFCS5 remained contained or did not migrate, because there is a historic group of this Royal Children's Natural History group, that any 4 and 5, about 80 to 90% or 60 to 90% would get sublux or migrated. So if in how many GMFCS 4 and 5 patients are there, Godha?
So 7, sir. 7 and 4.
Yeah. So there is very small number of patients, very small number of patients. But if they show that 90% of these patients did not migrate, then we can think of considering this intervention. Secondly, at what point, we should do, should we do it prophylactically, or at what migration percentage we should start doing, whether it's 35 degrees and then you put a screw, or at more migration, because more than 35-degree migration is considered as subluxation. So I think we can do at that point and see whether it remains sustainable or not. So I will go in details of this paper. I have to read. I just read the abstract, and then we'll see. But to me, it looks like the primary thing is a standardization of X-ray is important. The case example they have shown, it's not, it's an X-ray in external rotation. So we need to go through this in greater details. So we should also see in how many percentage of patient we can avoid the varus derotation osteotomy, because for 4s and 5s, they are to doing a VDRO and DEGA is a very, it's a major surgery. Again, the question also is, we see posterior deficiency of acetabulum because of persistent flexion deformity. So how acetabulum development, acetabular index is not reliable tool to see acetabular development. We have to see a global acetabular development. So these are the limitation of this paper, I think. But this is one of the options we can consider, and I will go through in details and share with you what I think about it, where we can apply it. Fine. So we have overshooted the time, but these are great papers. So if we summarize, the first paper needs clarification about the radiocapitellar congruency, whether it is the same as the neck radius fracture. The second paper, vertical talus, we cannot apply in our practice. The third paper was on the 4-in-1. Yes, we have been doing that, so it will not modify our practice. The last paper, again, very small number of patients, and we need to be careful before we start doing this procedure in our patients. So thank you very much for your time and teaching us, all the fellow. We'll meet next week with some interesting sessions. Take care.
Thank you, sir. Thank you so much.
Bye-bye. And best of luck, Shalin and Chinmay, for your sick kids thing. Let me know if you get the news. Yeah?
Yes. Thank you, sir.
Bye-bye. Gaurav bhai?
Gaurav bhai just નીકળે છે.
Yeah. શું છે બીજું? શાલિન શું કરો છો આજકાલ? હવે મુંબઈ થી આવી ગયા?
હા, આવી ગયો અને વિઝા બી અપ્રૂવ થઈ ગયો.
વાહ વાહ. તમારા બંનેના?
ને મારો તો હતો, એટલે મારો એક્સપાયર થાય છે નેક્સ્ટ યર ફેબ્રુઆરીમાં, એટલે રિન્યુઅલ માટે નાખું, બટ આ બધું કેનેડા ને એનું પતે ને એના પછી.
તું કેનેડાથી જ અપ્લાય કરજે.
હા,
ત્યાંથી સરળતાથી મળી જશે.
હા, કારણ કે અહીંયા પેલું અપોઇન્ટમેન્ટ નો બી બહુ લફડા છે મને.
અમારે અપોઇન્ટમેન્ટ મારા એક્સપાયર થઈને 4 વાર થઈ ગયા, તો અમે માર્ચની લીધી છે અપોઇન્ટમેન્ટ. હમણાં અમારે જવાનું નથી, પણ ઇફ યુ આર ગોઈંગ ટુ કેનેડા ત્યાંથી સરળતાથી મળી જશે.
અને એમ બી ફેબ્રુઆરી સુધી તો છે, એટલે કદાચ ત્યાં સુધીમાં જવાનું થાય તો બી ઘણું બધું કવર થઈ જશે. અમે વી ગોટ અ હાઉસ ધેર, ત્યાં આગળ, એટલે રેન્ટલ ડિપોઝિટ મોકલી દીધું. આનું
જ્યાં તમારે રહેવાનું છે ત્યાં
અમર સરે કીધું he had stayed there, અને ઓન કેમ્પસ જેવું જ છે, જસ્ટ 300 meters walking, એટલે એ ફાઇન છે.
અમે તો એટલે નજીક હોય તો સારું, કારણ કે there will be snowfall ને બધું પણ હશે ને, એટલે થોડું સાચું પડે. નજીક હોય તો વધારે સારું પડે. Great. So you are going to have best time of your life. Yes. એટલે એન્જોય કરજો.
Yes, sir.
ઓકે ચલો કંઈક હશે અહીંયા તમે એટલે કે હમણાં અહીંયા જ છો તું
હા, હા, sir.
કંઈક સારું ટ્રીકી હશે તો કહીશ તો આવજો તમે
CVT next week આવીશું.
હા તો આવું છે તાર તો આ નીત લોકોને કહી રાખ
હા.
પેલું મિની ઓપન કરવાનું છે તારું લિસ્ટ મોકલતા રહેશે જે જોવું હોય તો આવજે
હા, sir.
આજે તો કઈ છે નહીં એક સીપી રિલીઝ છે ને એક ફ્રેક્ચર છે બીજું હા એક સિનોસ્ટોસિસ છે નેક્સ્ટ વીક ના લિસ્ટ તને કહેશે
હા, sir.
ચલો હવે પેલું પેપર છે ને આ એલ્બો બ્લોક ટેસ્ટ વાળું એ ફટાફટ લખી નાખ્યું છે મારે કારણ કે આ બધા ગંગાવાળા ના તે બધા they are like trying to publish whatever they have seen.
હા, sir.
હવે એ કરી નાખ્યું અને તું મીતને હેલ્પ કરજે ને MISR નો એસેન્શિયલ સર્જિકલ ટેકનિક માટે
હા, sir.
હે ને
હા, sir.
સારું ચલ મળીએ છીએ
હા, sir. હા.